Hello and welcome to our Thursday weekly virtual webinar. We are so glad that you guys have joined us, and I want to just take a moment before we get started to say I appreciate all of you taking the time to get educated on what is happening at the hospital. With this heat and our bad air and COVID, it kind of seems like every time you wake up, you're like, what's going to hit me today? But we are all alive and healthy and well, and I hope you and your families are as well. Today is August 20th, and hard to believe, but this is our 24th weekly virtual meeting. My name is Deborah Volleson, and I'm the Director of Community Engagement here at Kaweah Delta. And today I'm very excited because we brought back Carrie Noeski, our Chief Nursing Officer, and John Knudsen, our Director of Critical Care. They joined us a couple of weeks ago, and I appreciate all of the positive feedback that we received on them joining us, and they were gracious enough to come back today. So we're really excited to have them. Not only are they going to answer the questions that you guys have submitted throughout the week, but keep in mind our chat lines are open. You have my personal email. Some of you even text me during these meetings. So keep those questions coming. It's not often that we get to sit down in the room with our clinical experts, but today we get them for an hour. So we're very excited to welcome them into this room. One more thing is we do post these in our community engagement private Facebook page, and they will be on the COVID-19 page of Kaweah Delta. We break them up into individual questions, so if you're confused about something that is spoken here today, you can go back and look at the written answers to the questions on our page as well. Okay, so at this time I'm going to bring Carrie and John into the room. I feel like we need a band.
So excited to be back.
We need a band or some sort of musical interlude to add here. Thank you guys.
I'm not opposed.
I'm a little worried. I want to really meet expectations.
I know.
I know. Glad to be back, but I feel like the bar is pretty high. So
This is true.
Well, you set that bar, so.
I know. We really need to work on that.
Yeah.
Thank you for having us.
Okay, well, thank you guys. Let's jump right into the questions, and we always like to start with our current numbers. So, Carrie, why don't you jump in with our numbers?
Okay, so I know Gary goes into great detail for everybody on these numbers, so I'm going to try to do it some justice. Right now, the positive cases in the county, and this is from the county website, most of these are from yesterday. It may have been updated today, but positive cases in the county, 12,836. And then deaths in the county, 208. Recovered cases in the county, 11,520. And then for our positivity rate that's posted for the county, it's 13.8%. I do believe it's starting to trend down. That positivity rate is based off of confirmed test results, sometimes data coming in for all the Tulare County tests, or Tulare County residents that are tested is 7 to 10 days behind. So it does adjust. So that 13.8 is based off of the that they had all the test results were in as of 8/12. And as they get more confirmed test results, they then continue to update it, but they only update it publicly every Thursday. So that's updated on their website, but it's also about a week behind. So efforts that we're making this week may not be reflected in that rate just yet.
Okay, what about the hospital?
So our census is at 291 total patients in the hospital, about 90% capacity. We have 43 patients that have a COVID diagnosis as part of their stay, and one of those is a pediatric patient, that's 16. And the rest are adults in various areas. We've closed down our pods. We had pods within our medical surgical units when we saw our census grow. We had pods of patients on 2 North, 3 North, and 4 North because we just needed more capacity for patients with COVID. Those units no longer have those COVID patients. All of our COVID med-surg patients are on 2 South again. Mm-hmm. And then we have patients in our intermediate critical care and our ICU. ICU has 9 patients, 5 on ventilators, mm-hmm. and 3 West or intermediate critical care has 11 patients.
Okay, all right. So we are really seeing a reduction in our COVID positive patients hospitalized?
We really have. There's been significant work this month by our community. That's the only place to contribute this reduction in cases, this reduction in hospitalizations, is our community really grabbing hold of protection and social distancing, hand washing, masking, not gathering. We're continuing to then drive the message that this is what's working, and this is exactly why our positive cases have gone down and our hospitalizations have gone down and stabilized right now in the 40s for about the last week, and that we need to continue to do that while balancing getting out there, interacting. I'll admit I did go out to an outdoor restaurant last night. It was amazing and wonderful to distance and sit and enjoy dinner with a friend, and we do need to do that. And there's a lot of things and a lot of decisions that are being made right now. It's just that balance. It's really that distancing and safety while getting back into our activities.
You know, when I looked outside today and the air is atrocious. My husband made a comment about, be careful, the air is really bad today, but I'm like, we're all wearing masks. It's great. So maybe that'll even stop like the fall allergies and.
Yeah, I do hope that everybody wearing masks, we see some, boy, I'm really hopeful that we see a healthier fall and winter. You know, I can't say for sure that will happen because we just don't know what will come next, but the science of it is if people are wearing masks, we're not going to spread the flu. Mm-hmm. So I'm very, very hopeful that will have a positive impact on our typical flu season.
Right. Now, what about our positive employees? Has that dropped as well?
So we have less people out on leave right now. Yes. So we have a total of 322 employees that were positive or quarantined because of a family member being positive since March. 255 have recovered, so we have 67 on leave, and that was as of Tuesday this week. We update that again weekly, but we are seeing more come back from leave than go out on leave, which has been great. We have not had outbreaks on units. We have our staff are really doing a great job of maintaining the safety, maintaining the protocols, screening patients. We screen patients every shift for symptoms, try to catch them as early as possible. And then if we identify someone that wasn't symptomatic when they came in and now they're symptomatic, we get them tested, we get them into isolation while we wait for the test results, all those things. So.
Okay, so what is the hospital's positivity rate?
Oh, I think, see, that's on Facebook, so anybody could fact check me on that one. So it was on Facebook last night, and I read it because I even emailed with Laura about it. It's over 8.
Okay, we're going to get that. We'll get that.
Let's get that.
John's pulling it up right now.
Tricky.
Sorry, I wasn't trying to be tricky.
Yeah.
Okay, so John, although you are trying to pull that up, let me ask you this. If our numbers continue to go down, our hospitalized COVID positive patients, will the visitor restrictions be lifted?
Oh yeah, good question. One of the most difficult things that we did early on in this pandemic in March and April was restrict our visitors. Going into the hospital is a horrific thing. It's usually a very, very bad thing, unscheduled thing, or a happy thing, having babies and doing things like that. And so restricting visitors for either one of those is a very emotionally charged decision that we did not take lightly. But it has helped decrease the spread. So we have allowed visitors under certain guidelines to come into the hospital. Most people are familiar with it by now. Having a baby, children who have to be admitted, patients with developmental needs, special needs, end of life. We look at patients who are deteriorating or times where we might need family members to come and help make difficult decisions at the bedside in collaboration with the nursing staff and the physician staff. We have people come in for those instances as well. So we continue to allow those to happen, but we watch very, very closely all of the statistics we report on and look at with the county and state. and our government for guidance as to how things are going, levels of opening in the communities, and really make our decisions in collaboration with all of those other factors. So we anticipate, yes, we would like to open up in the future strategically as, the science and communities allow.
Is there a baseline that you've set for that?
We have not set a baseline, right?
Right.
Just because I missed something.
No,
not yet.
No, we have not set a baseline, and it will really be dependent on that state guidance too, because the state has given us guidance to restrict visitors. So we would do it aligned with that and align with kind of what we're seeing in our county. But I think we've been trying to be a little bit more liberal with the decision making because we have more control over the environment. And we have our staff are able to monitor it closer and monitor where visitors are. Because one of the barriers if every patient has a visitor, it's really keeping them safe. And with our staff, and we've talked about our staffing needs and our crisis, it was one more burden to try to keep everybody where they needed to be and make sure people were following our protocols. So, yeah.
Okay, so this question just came in. So how is the number of recovered COVID patients derived? Are they all being retested?
So the county number is not all retests. No, they use the recovery strategies that are put forth from the CDC. So the county public health nurses, and there's an array of them. They are assigned the active COVID patients in the county, and they follow up with them at regular intervals. I think there's certain number of days throughout it, and check symptoms, check how they're feeling, redirect them to medical attention if they need it when they're checking in with them, if the person hasn't already reached out for medical help. And then once the patient has met either 14 days since the positive test, and that's only used when the patient has no symptoms, which we know is one of the many problems with this virus is you don't really recognize the symptoms or you don't have them at all. So 14 days from the positive test, and then the other thing is if it's been at least 10 days and since the patient was symptomatic or since symptoms started, if it's been at least 10 days since that point and they've gone 3 days without symptoms, primarily a fever and some of the more respiratory related symptoms, then the patient is considered recovered as well. So, and those are CDC strategies which align closely with viruses too.
Mm-hmm. Okay, so if the standard is to test, if the standard to test is symptomatic, is there such a thing as schools asking for routine testing?
So yeah, there are schools that are trying to implement routine testing. So the symptomatic testing is based off of the scarcity of supplies. So when the CDC says you should test symptomatic individuals first, healthcare workers second, and then exposures and on down the line, that's in relation to there being a limited amount of supplies. As more companies come out with testing capability and more platforms come out, there's a little bit more access for people to test a little bit more liberally. Mm-hmm. So there are stories in the media that schools have access to testing platforms and they're able to test their students to get a baseline. We know that our opening of our sports teams, our professional sports leagues, has happened because they're doing routine testing in, I believe, in baseball and hockey and basketball. So those areas there is the accessibility of it. Mm-hmm. We at Kaweah do symptomatic testing because we have limited supplies. That's kind of where we're at right now. We are on a federal allocation, and because we're a healthcare organization, we're allocated supplies from the federal government that we get through vendors, but we have to use them judiciously. We're working along with everyone else to get access to more supplies so we can help contribute to asymptomatic testing. So testing those people who think they may have been exposed, or testing those people that don't know if they were exposed but they have a sore throat and maybe have had a fever. And those are the ones, that's that asymptomatic testing or non-exposure testing that will help contribute to the negative cases in the denominator for the positivity rate. So we don't have the ability to do that yet at Kaweah, but counties across the state, that's what that's what they're aligning to do. So they're trying to set up increased testing so they can capture more of those individuals that are asymptomatic, that would help with decreasing the spread, as well as just opening up that denominator of negative cases in there too.
Right.
So, and then Kaweah's positivity rate 14%.
Okay.
And that, if you see though, that is very close to the county's rate. So, we probably do have some opportunity there countywide to increase testing. Kaweah is working to do that, and I don't know if Gary has talked a little bit about the work we're trying to do, and we're getting closer. We just need to get access to the test kits, and then we'll be able to set up more robust testing throughout the community.
So the question came in actually after the meeting last week. So if we're only testing symptomatic people here at the hospital, then of course we're going to have a high positivity rate. So how do we decrease that positivity rate? And I know that would come with testing supplies.
Right. So the hospital positivity rate isn't something that is being used to make determinations for the county. It's just something we track for our own awareness. It's good to have data so we know where we're at. And our numbers do contribute to the county numbers. We send everything in, and so when the county puts their positivity rate, they use Tulare County residents tested at all labs. And so anything that they can get a hold of, so they put into their numbers. We just track ours for our information and awareness, and then want to try to help the county though with the testing platforms. And the county we've been working with the county, and they're appreciative of that willingness to say, let's help you test more people.
Right.
The county's tested, total across the county, that Tulare County residents who have been tested is 110,000. That's how many Tulare County residents have been tested as of yesterday, in just a situation report that I received. And so that's all those labs.
Yeah.
And
Well,
that's
and wouldn't you think our allocation would kind of be a little higher since we're the fourth in the state? We were even, President Trump did a press conference, I believe last Friday, mentioned us by name.
I know,
Shouldn't
notoriety.
they increase our allocation for testing? I can't believe we're struggling.
So they have, they increased our allocation, but to supply more kits, to increase the supply, they had to actually redo their production lines. And so this is definitely getting out of my expertise of healthcare, but the production lines at the labs had to actually be stopped and revamped or recreated and then restarted. And the second one actually created a new facility to create more kits. And then whenever you start something new, you have to stop and quality test it. And they had a failure in their quality control, so they couldn't ship those kits. So that was one area. So there was this plan to allocate more to us. We're just waiting for them to make more, to send us more.
Right.
But there is plan for us to get more. Plus, we were able to tap into that Kaweah platform that I know Gary has mentioned. And they as well were commandeered by the federal government and are now in an allocation mode too.
Oh, so even though we had grand plans to order this large amount, the government found out about it and said, oh, we'll allocate those to you.
They found out about Kaweah being so successful with manufacturing, but we will still get our kits.
Yes.
So we were ahead of the curve enough that we will get our kits. It's just getting them out and around the through the process now that's in place because of the allocation, but we'll still get the kits.
Okay, perfect. So John, the question came in about face shields, when to wear a mask, when to wear a face shield, and when can you wear a face shield and not a mask? Can you clear up the face shield question for us?
Yeah, sure. So the question was, when is it okay to wear a face shield without a mask? And the short answer is never. The long answer is don't do that. Remember, when somebody coughs or sneezes, that's the long answer.
That was a long answer, okay.
When somebody coughs or sneezes, remember they're projectiling water droplets, and they shoot out 5, 6, 7 feet, which is why the 6-foot social distancing is so important, because that's the science behind how far a sneeze or cough traditionally travels. And so if somebody is relatively close to you and coughs or sneezes, the face shield alone is going to block a lot of those droplets. But the things that are not quite heavy enough to shoot across a space are in the air and can still get behind that mask, and you breathe it in, which makes it essentially almost pointless to have that without a mask. And so it's a great adjunct to wearing a mask. Masks still super superior to not having a face shield. Having a mask and a face shield, double coverage, but by far it's most important to have a mask on, not just a face shield. I think we've used the analogy before about safety in vehicles. It's great to have brakes, but it's even better to have brakes and a seatbelt and an airbag. Have most of the things available to keep yourself safe, and don't skimp one way or another.
Right,
Yeah.
okay. So the dean of COS reached out to us, a dean at COS, and they started their labs this week. And labs, of course, have to be in person. And so she was wondering if there was a spike in COVID, would the tracers be able to provide that feedback to COS so that they would know and be able to plan for those future lab usages?
I think, were you going to take that question?
Either way.
Go ahead.
Yeah. So yes.
It's called collaboration.
Yes, right? Yeah, so that.
See what we did there.
A lot of days. A lot of days. If a student comes up positive, and the county will be alerted, and the county will get in touch with them, and the county then will interview and ask them who they may have had contact with, and where the risks might be. And so it would be reliant on that student reporting to the county public health nurse, I am a student at COS, yes, I am in a biology lab, and I was with some other students. And then the county would then call and let the school know that there was a possible exposure for other students in the program. A couple other ways to minimize risk is, and probably things you already have in place, are the distancing, the masking, and the frequent cleaning, and the isolated workspaces, so students aren't working with each other, that they have their own space and they clean it down afterward, and that's the expectation that they always have the masks on. And we do shields in our patient care areas, so a shield would be another great level, and just good for them to get used to the shield. And then they don't intermingle, they stay that distance apart. It's going to reduce the risk that if you do have somebody that comes up positive because of a community exposure, much less likely that they'll pass it to any of their other classmates. And then the other piece is, I would expect that the student, if they're going to be absent, is calling to say, I'm going to be absent, and there's a requirement that you have a note of some sort. There's probably rules around what you can and can't delve into health-wise, but I think that if it was something where they had exposed it, I would expect that there'd be some responsibility within for confidentiality, but within the college leadership to say, okay, if it was COVID, I'm going to alert other students that they maybe were exposed, but not have to disclose who that was.
But we're not concerned about surge capacity right now if there was to be a surge in the labs at COS.
So we're always worried about surge,
Right.
But we do have capacity. I absolutely hope that you don't have an outbreak and that you have to go that route. But yes, we have capacity for patients, and we are not using. We are actually using some surge beds, but it's more for relief of staff. We have opened up some surge beds at our West Campus for medical surgical patients, but they're over in our rehab acute hospital being cared for by the acute team over there. And it was more a matter of just alleviating some of the numbers of patients here. And since we started it, we've just continued to do it. So it's 5 to 10 patients. It's not a large volume, but it's just enough to shift some of the staffing pressures off of the acute staff at the main medical center, and in using the acute staff that's out at rehab to do that care. But overall, we do have beds. We we're about 90% capacity today, but that's not using the surge beds.
Right.
Yeah, we're very interested to see what happens after Labor Day. It's shown historically when we had Easter and Mother's Day and Father's Day and Labor Day and 4th of July.
Not Labor Day, Memorial Day.
Memorial Day? Oh, yeah. Optimistically
Your
speaking
years
about
all
the future.
running together,
Yeah. That we did see within 3 to 5 days of those weekends, we saw a bit of a surge. And
Right.
so we're thankful and happy that the community's been doing their part in reducing the spread. We've seen, as Carrie mentioned earlier, a very nice trend going lower, and we hope to see that continue, but we'll be prepared for surges in the future.
Yeah. And thank you, Jonna. She's just commenting that COS is taking extreme caution with social distancing, masks, disinfecting each lab station. And we had no doubt that COS would be on top of it.
Yep.
And we're just going to cross our
Yep.
fingers and knock on wood, as John would say, that everything's going to go well. And maybe the virus is kind of easing up on us a little
Maybe everyone will be
bit.
so busy with distance learning that they won't
Yes.
have time to gather. So,
Maybe.
Yeah.
hi, Jonna. So,
Okay, so this question came in, and it's been asked a couple of times, and so somebody has asked us to compare the numbers we are seeing with COVID-19 and the flu season. So can you share with us, so during the flu season, we often have multiple tents outside the ER, the hospital's running over capacity, but we don't report the numbers of flu like we do the numbers of COVID. So can you give us some numbers comparing that, Carrie?
I can, and I'm sorry, I'm going to kind of look at my papers a little bit because I looked at this last Friday and I haven't reviewed, and it's really impactful to hear the numbers and understand the difference in COVID and the flu. So when we talk about flu season, we're talking about a 6-month period, October to March. Beginning of October, end of March is that highest flu season. And right now, we're not quite at 6 months of our COVID presence here in our area. We started mid-March, so we say maybe we're about 5 months into it right now. The tents right now outside the ED are actually not because of capacity. They're for physical separation. They are to allow us to separate patients who we suspect of having COVID or some respiratory illness, and we can separate the care for those patients from the ED population, which was is very critical in reducing the spread. So that gives us the distance to do that. It is not actually because of holding patients, which we have seen in past flu seasons. And we, so there's the piece with the tents. Flu volumes the last few years have been increasing, and this past year, so 2019 to 2020, we actually had 4,273 cases of the flu detected through Kaweah Delta. That's not hospitalized. So 4,273 cases of positive flu within our Kaweah Delta entities. 339 of those patients were hospitalized. So to give you, so that's over that 6-month period from October to March this past year. In the COVID response time, we've had 3,345 patients test positive for COVID through Kaweah Delta. Again, this is just comparing Kaweah to Kaweah. We've had 720 of those patients admitted, or we've had 720 patients admitted. So we've had over double the number of patients need hospitalization for COVID-19 compared to the patients that needed hospitalization for the flu.
So less number detected or diagnosed.
So
but
more
double.
detected. So through Kaweah Delta, we had more flu cases detected.
Right.
Now the count, and I don't have the county number, I apologize.
More flu, yeah.
Yeah, so we've had more flu than COVID through Kaweah Delta. And I don't have the county flu number of cases to compare that to. But over twice as many admissions in 5 months compared to 6 months. So it does devastate people more. It does take out their systems more. It creates worse breathing problems. And then because of the lack of oxygenation that happens with COVID, you don't have the oxygen going to the organs. So then we're seeing more of the end system failures. We're seeing organ failures. We're seeing confusion. We're seeing just the delays in processing and cognitive issues. And then there's the recovery afterward, after being hospitalized for so long, or just even at home, people that low O2 saturation for a prolonged period of time. While it doesn't have, maybe, we don't know yet if it'll have permanent long-term disability, but it does take them a long time to recover, a long time to get back to normal. We don't see that with the flu. The flu doesn't ravage people's systems like COVID because we've been exposed in some way to the flu. Our bodies are ready to fight the flu. Even if we become positive with the flu, our bodies are ready to fight it. COVID, novel virus, our bodies are not ready to fight that, and that's the difference in why it's so important to tell people about COVID and explain about the effects and try to get people to stop the spread. And we can treat people that have COVID, but if the healthcare system gets overwhelmed, we can't treat everybody. The surge beds and the doing care in conference rooms decreases our ability to take care of people and increases our risk of our healthcare workers getting sick, our healthcare workers being off on leaves and not being able to provide care, whether it's to patients with COVID or patients coming in after a trauma or a stroke or an MI. We're a big health center here in the Valley. We've got a lot of people to take care of. So that's really that focus with, you don't really want to get COVID. Early on I said, it's kind of inevitable if you're exposed to it. You might get it, and that's still the case, but if you can protect yourself from getting it, that's even better.
Okay.
I'm glad you're able to find those numbers. That's about
Yeah.
an 8% admission rate for flu, almost 20 or a little over 20% for COVID. And remember, flu's been around for forever.
Plus,
and
we have a vaccine.
we have a vaccine. People get vaccine year after year after year. We have the benefit of being in the Western Hemisphere. Usually the flu season starts in the Eastern Hemisphere, so the CDC and World Health Organization looks at how the flu is affecting this year and start developing vaccines, and it makes its way from South America to North America. By the time it gets to us, we're typically a little better protected year after year after year. And the novel coronavirus just means new, unknown. We don't know what it's going to do.
Right.
We still don't know everything that it's going
But
to do.
isn't it weird how we did watch it progress closer and closer to us?
Yes.
I mean,
Yeah.
I believe the first official reported case was like December 30th, I think, if I remember right. And then our first case here at the hospital, Carrie, was
March
March
16th.
16th. Knew she knew
that
that.
was awesome.
So within 2.5, just under 3 months. So it made
Yeah.
its way from, East Asia all the way over to us, and yeah. So it's been interesting to watch the progression, but it came so quickly, and it was so new, and we just watched how it was devastating other folks that all we could do was prepare for the devastation, sit and hold on, and try and do everything we could to minimize what that devastation would look like.
And I can remember back in March or April, we were saying it will probably go away with the heat. Maybe it will go away with the heat, kind of like the flu does, kind of tapers off as the weather changes, but this has been exactly the opposite.
Yeah, so the reason the flu goes away with the heat is mostly because in the summer we do more outdoor activities. So it doesn't actually kill it, which I think it seems like that would be what it is, but it's more a matter of we separate more. But that was not the case with coronavirus because nobody has any immunity to it. And people were gathering, and probably gathering more after months of being separated.
Right.
And one of the downfalls here in the Valley is then we tend to gather inside because of our weather and everything. So, flu doesn't ever really go away. It just kind of, it lessens, and then it comes back as we move back indoors.
Okay. So we have a question. So if I'm standing near my fence in my backyard and someone who has COVID-19 passes by on the other side of my fence, what are the chances that I can get COVID?
I'm glad you asked that because that's a good question, and it does brings into all the different pieces of how the virus is transmitted. So it's less likely that you'll contract the virus, but not completely outside the realm of possibility. But typically, when you're passing by, you're not really sharing the air, and especially outside, you're not sharing the air. Now, if that person coughed or sneezed, and the timing is right as they walked by you, and maybe they didn't sneeze in your face, I really hope that wouldn't happen, but
And there's a hole in the fence at the right. at the
right,
perfect-
yeah, I don't want, but they could, if someone sneezed or coughed right on your face, a little bit more likely, those particles are going to go into you. But the prolonged exposure is another piece of the coronavirus transmission. That's why we talk about large gatherings, or sitting next to somebody for a period of time eating. If you don't know if they're not within your bubble and they're not a person you're exposed to all the time, and you're not sure where they've been when they're not with you, type of thing, that could increase your risk because you're in that space together for a prolonged period of time. But and I know we've talked about this before, Lowe's and Home Depot, and why is DIY okay, but schools aren't? It's really because of that passing. You're not in shared airspace with people for a prolonged period of time. But that's where that 6 feet of distance come in. And just to be on the safe side, I would try to keep that distance whenever you can for people that you don't know, or wear a mask. But in your yard, you're outside, doing home activities, you don't need to have a mask. You just need to be aware of where you're around. But outside is definitely a much less risk of transmission.
I love that question because I'm a visual learner. So back to the face shield question. Face shield, chain link fence. Mask, double layered wood fence.
The good neighbor fence.
Yeah.
Yes, double layer. Yeah.
There you go.
There you go.
Okay, so a question was just texted. How much longer will the military health team be at Kaweah Delta?
Oh, man.
Yeah.
So
They're
sad.
14 days, right?
Go ahead. Yeah.
So at this point in time, their extension was through the end of next week. August 28th is their last day scheduled here, and then they're redeploying on the 29th. But we're still waiting to see if we have an additional 14-day extension. And we've requested it, and I actually did an email this morning just to follow up and see where we're at, and I have a call this afternoon I'm going to ask on too. Because if they don't have to be anywhere else, and we still have the need. We still have patients we're taking care of. It's really been amazing for our staff to have that extra support, and everybody has just loved having the teams here. So our hope is that we have 2 more weeks, but in reality, we're planning for next Thursday, and then a happy surprise if we can have 2 more weeks after
Right.
that.
So once they leave, are you worried about staffing?
So we have, I'm always worried about staffing and staff in general, but we have actually onboarded 176 RNs since March. And a lot of those have completed orientation, are completing orientation in the next few weeks. I talked to a nurse this morning. This was her last day on orientation. I'm like, you've got this. And she's excited. So I am not as worried as I was during the peak of our COVID response here in July, when our hospital was at 95% capacity. But we're not done planning for it. So we're still onboarding nurses. We're still doing weekly orientation. We're still looking at staffing in our other areas too, and how do we realign staff for the increases in volumes, and where do we need people the most, and to keep patients moving through, because there's nursing staff at the bedside, but there's the procedures, and there's the care throughout the day, and there's just the increased demand. So constantly looking at all the avenues.
Okay, so a text came in. Why is it okay for Carrie and John to sit next to each other without masks?
So
Your bubble.
yes,
It's
no,
your
that's,
bubble.
that's
Yeah.
a very good point. So
It is a wide angle lens. We're really about 22 feet apart, actually.
So we have some distance here, but John and I are kind of in a bubble, and our spouses actually both work at the hospital too, and so we have this 5 months together, kind of a lot of time spent working together. So, and know each other's habits outside of work, and know the caution that's taken by both families. So it's kind of developed into our own bubble. But nobody has ever asked that in the last 5 months. I am proud of whoever asked that, because I often do wonder, what people think about that. So, but we do work to have a lot of distance here, and everybody else in the room has their masks on.
They're all masked up.
So we have that, or they're significant distance away. So, but good question.
Yeah, thank you. Okay, so I'll share.
Wait, does that mean they prefer to see us with our mask on? Because they don't.
Okay, question has been texted. Should we be hitting flu shots now? Should we be getting?
Getting them probably auto-corrected to, yeah.
That's okay, Sam. We'll change it
Yeah.
to getting.
Yeah.
Or is it even ready?
So I think that there are flu shots out there. It's okay to start as soon as they're available. It's absolutely okay to start when your providers have them available, or you see them at any clinics you usually go to. That's absolutely okay.
Well, are you watching trends? Does it look like we're going to have a big flu season this year?
The infection prevention department is watching the trends in Australia. That's what we usually do, is we watch that area. I think John mentioned that. And they are mild to start. It is mild. So we're keeping an eye on it though. But we've seen that too. I don't want to discourage anybody, but we've seen that here where October, November, December, very, very mild, and then it hits in January. So we're still cautious and still preparing for the worst, and preparing for a bad flu season topped with COVID, topped with distance learning and social isolation.
But we usually we get our batch of vaccine the end of September, and usually start getting all of the employees and offer it at our various areas beginning October 1st.
Okay, thank you. We need some good news. Murder hornets, COVID, fire tornadoes. Really, we need a good flu season. We need a good flu season.
That's true.
Do. Yeah, I'm very
Okay,
hopeful.
so I'll share a story with the both of you, and you can tell me whether or not you agree with this. So you all know that testing has kind of crippled a lot of our organizations. They feel like they need to get their employees tested, yet 17 to 20 day turnaround time on asymptomatic employees, that's just, not really working for a lot of our organizations. So an employer called me the other day, and they had a patient, or they had a person, an employee, that was possibly exposed. And she wanted to bring them to our Kaweah Delta testing site. So I explained to her that we are only doing symptomatic. It has to go through a doctor referral. If they are not symptomatic, they will be sent to a county lab. So instead, they went to a local physician's office, and the physician tested him for the antibodies, but then he told her, because she was tested last Friday, and I received the call yesterday. So Friday to Wednesday. Wednesday was when I received the call. So last night she told me that the physician told her that there's a window, like so many days window, that she would have started showing symptoms if she would have been exposed at the time that person was showing symptoms. And since she was past that window, they did not feel like she needed to be tested. Is that true?
So yes, so that falls into that recovery strategy. So if you thought you were exposed on the 1st of August, and then you started showing symptoms on the 5th, but you didn't go to the doctor until the 13th, or let's say even the 10th, but your symptoms have stopped. Now it's been 9 days since the exposure, and it's probably past you're almost to that end of that recovery window that they say you're not contagious anymore if you've been 10 days since your symptoms, or since your exposure, and at least 3 days since your last had symptoms. It falls into that. So it's probably something along those lines, with the provider using that CDC strategy for recovery, and that's probably why you test her for antibodies instead, because if you're already feeling better, then your body's form the antibodies, and they'd be in your blood. They usually recommend more like 30 days after, but it could show up that early.
Yes, some of those point-of-care tests look for, so the antibody test, and there's some here in town where private physicians' office and clinics offer this, and it's a blood test. And it looks for two things. It looks for different types of immunoglobulins. There's a G and an M. One looks for acute active virus right now, and typically it's when you're symptomatic. And like Carrie mentioned, it takes a bit of time to develop those symptoms. In fact, it still holds true that about 5 days into getting infected with the virus is when you'll start to see your first symptoms. So you could be asymptomatic carrier for up to 5 days on average. And so if you get a test to see if you have the virus prior to then, you might not have enough virus to show that it's positive. The other immunoglobulin test looks for antibodies. So that's if you had the virus and recovered and it's been 3, 4, 5 weeks, it might be positive there. So some of them look for both things, and if it's too soon or if it's not going to make much of a difference because you don't have any symptoms, then not going to be a lot of benefit to testing. Yeah.
Okay, well, we have answered all of the questions and the text messages that have come in. Let's see. Why can't they wear masks and do their presentation? I've worn a mask while doing presentations in court.
Oh, we absolutely could. We just didn't want to disrupt any of the message, and because we can't get the feedback if people are, by watching people, if people understand or not, then we usually take them off. But
Yeah.
definitely appreciate the importance of wearing the masks, and we just kind of throughout this whole pandemic, as we've done these huddles and we've done these town halls and the different webinars, we've just taken them off so we can make sure that people can see our expressions and everything can come across clearly.
Right. And I'm going to go back to the bubble. There are people who we've all been around during this pandemic that are our bubbles,
Yeah.
and that we feel safe around. I feel much safer around the group that's in this room than walking down the grocery store aisles or Lowe's. So, okay, so Carrie, John, do you have anything else that you think would be important information for the community?
I might add one thing. We continue to work very closely with our surrounding hospitals, larger organizations, smaller organizations. Just this week, we sent a group to another large organization down in Southern California, and we have contacts in Fresno as well. And we work with those hospitals to look at best practices. What are you doing that might be different than us? What are things that we can learn from that you're doing? What are things that you can learn from that we're doing? And I'm pleased to say that when they came back from this large hospital, there really wasn't a whole heck of a lot of things that they were doing that we felt like we were missing out on. We've been looking at the same research and doing the same studies and implementing the same things, and I think our community can feel very confident that Kaweah Delta has done our best to make the best decisions for our patients, for our community, for everybody that comes to us. And we felt very good about that. There were a few interesting things that we thought, oh, that's kind of a neat idea. Nothing profound that was going to change entire processes, but we felt very good knowing that little old Kaweah Delta in the middle of California is keeping up and doing all the amazing things that many of the other larger organizations are doing. So
Right.
that made us feel really good. So I want to share that with the community.
Yeah, thank you. Sierra View, since we're working so closely, are their numbers going down as well?
They are.
Okay.
So we partner closely with the other hospitals here in our county, but then in the valley too, just because we're all have similar challenges and barriers that we've come up against, and it's good to bounce processes and ideas off each other and make sure we're working in conjunction with each other, so patients don't go from one facility to another and have different information. And it's really been a good collaboration. But Sierra View, yes, I believe earlier this week when we talked, their numbers were in the low 20s,
Okay, good.
which is great for them, and that things have stabilized, and they had about 20 to 25% capacity, as well as some critical care beds. And that the state really watches the critical care bed capacity. The med-surg capacity is important, but the critical care bed capacity worries them. And we've told the state through a couple of different avenues that our biggest concern is not so much bed capacity and equipment. I'm sorry, not so much equipment capacity like ventilators, but it's the beds and the staff. It's the space and the staff, and really the staff to take care of people. Because we could open up another critical care area in some of our places of our hospital, but we wouldn't have the trained staff to do the care, the intensivists, the respiratory therapists to maintain high levels of critical care need.
Okay, so as our numbers continue to drop, are we going to increase the non-emergent surgeries that we are performing?
Yeah, actually, we did. We opened up to a few more cases even this week, and brought in some additional cases. We didn't want to overload it too quickly, but we did start taking in more of the elective cases that would end up in inpatient beds. So some of our push towards 90% is increased in surgery patients too.
Okay, fabulous. Well, thank you both for joining us, and
Absolutely.
thank you
Thank
to
you.
all of our attendees who are on the webinar right now. I appreciate the time that you guys have put into the success of this webinar, and I appreciate all the questions that came in advance, and we just want to wish everybody a happy Thursday. We hope you all have a safe and healthy weekend, and thank you.
Yeah,
Goodbye,
thank you.
everybody.
Take
Thank
care,
you.
everyone.